All right, thanks everybody for joining. We're going to get started. This is Carol from the STS. This is the Adult Cardiac Surgery Database monthly webinar for September 6th, 2022. On the call, on the lines with us today from STS, we have Leanne Jones, Emily Conrad, Melinda Offer, and Sydney Clinton. And from IQVIA, we have Joe and Michelle, and we have Nancy Honeycutt on with us as well. Thanks, Nancy, for joining. I see some hands raised, but I'm going to get going first and then we can do that. If you have any issues, put it into the Q&A, please. Okay, so STS important dates, STS updates, IQVIA updates. Melinda's going to give us a educational presentation on postoperative stroke with some polling questions, and then we'll do Q&A. Important dates, we had our harvest closed for harvest 3, which is OR dates through June 30th, 2022. That closed on August 26th. That data is at IQVIA now, preparing to be sent over to DCRI for analysis. Probably takes about 6 or 8 weeks to get that data back. So we should see it. I think we usually see it the early part of October. So hopefully we'll see it again at around that same time, maybe mid-October. We have our monthly, we're at September 7th today with our monthly webinar. We have our user group call on September 21st, monthly webinar on October 5th, and then we'll be in Rhode Island October 26th through the 28th, and adult cardiac will be on Thursday, October 27th. We closed harvest 3. This report will be coming out probably mid-October. And then harvest 4 closes on November 18th. So make sure you have, you're prepared for that. If you're planning to go out of town or anything, take advantage of that early submission, the continuous submission, get your data in and cleaned up and ready to go. The September training manual has been posted. Registration for AQO is open. Currently, we're seeing a pickup in-person registration, which is great. So can't wait to see everybody in Rhode Island in October. And then this other item I want to talk to you about, the STS is through the Quality Metrics Task Force. They're working on a frailty measure. And the questions that they're coming up with seem very similar to me to things that we ask, that nursing is asked to screen the patient for on admission. So instead of making the wheel, remaking a wheel, building another wheel or whatever, I thought I'd ask you all on this call if you would mind, if you have access to your admission screening document so they can see the types of questions that are being asked. Currently, what this task force is proposing is that we would have a separate form that the sites are responsible to have filled out, and then somehow either scan it into the EHR and then enter it into the database using a REDCap form, since it's not built into the current data specifications for version 4.20.2. But as I was looking at these questions, they seem like they're coming from things like dysphagia screening, ADL, any type of ADLs, your activity of daily living screening. And it seemed very, very similar to me to things that we ask the patients on admission to the hospital as part of our nursing assessment of those patients. So I was just wondering if folks on here would be willing to send me their nurse screening forms. What I'm trying to avoid is having patients ask the same questions twice and putting more burden on the data manager to ensure that they instill a process to get these questions asked when they're already being asked on admission. So if you are able to share those with me, I would really greatly appreciate it. It would be your typical screening forms that are done on admission by your nursing folks. Okay, and then AQO, October 26th through the 28th in Providence, Rhode Island. Early bird has already expired, so we are at the standard rates. One track prices are here. I do ask, please, if you're going to join, please do join us. And I just heard from Melinda, I don't know how many military or retired military that are on here, Melinda, but did you want to share what you had found out about the hotel regarding that?
Well, I was just going to tell you that the government or military rate for the Omni hotel is like 155 a night, guys. So it's quite a big savings from the standard rate. So just FYI.
And so if you are contemplating coming and you are retired or active military or reserve military, I think it would be, that's definitely something to keep in mind when you're planning. So thanks, Melinda, for checking that out. Adult cardiac will be Thursday, October 27th. Just a note that the virtual pass will not have live streaming. So there will be no live streaming. The content from the live meeting will be recorded and then available to those that purchase the virtual pass, as well as those that are in person will have access to those recordings. We'll be at the Rhode Island Convention Centers. We are staying at the Omni Providence Hotel. And then here's more information. If you want to get a screenshot of that, you can. The price is guaranteed through October 4th for the AQO group rate. Preliminary topics we are going to talk about. We have quite a bunch of great presenters, some surgeons, leading surgeons in these spaces presenting to us the anatomical portion. And of course, our wonderful core group, most of our wonderful core group, and some other data managers who are not part of our core group, but very well-versed in these topics will be presenting on the coding of these sections. We will be presenting on the aorta, arch and debranching, AVRs with annular enlargements, mitral valve procedures, CABG anastomoses, bad ECMO and PELAs, and then a very great presentation from Dr. Horvath on database and value-based databases and value-based care. That'll be great information to take back to your team as you talk more about implementing databases within your hospital quality improvement projects. The TVT registry by Dr. Joe Bavaria, and Cath Echo presentation by Dr. Glenn Whitman. Everybody loves Dr. Whitman. So if you're coming in person, be sure that you're there for his presentation on the Cath and Echo. AQO is going green this year, so we will not be printing out any of the data collection forms or agenda books. Everything will be available on the internet. So if you need to have paper forms with you for note taking, please make sure you print those out ahead of time and bring them with you. And I'm going to hand it over to Joe for the IQVIA update. Joe.
Great, thanks, Carol. Good afternoon, everyone. Just some reminders of some items that we are working on over here at IQVIA. First, in regard to the participant, the non-analyzed dashboard report, we do have some enhancements on the way, which will add many new variables to the report. So for the first phase of these enhancements, we're going to be updating post-operative events, risk factors, preoperative cardiac status, coronary bypass, preoperative medications, and discharge and mortality. So be on the lookout for that update, which should be coming sometime later this month. And again, that will add more variables to that report so you can get more data reported out of it. Next slide. Also, we will be improving the predefined date range option selections. So when you're going to set up your report, when you click that drop down for the dates, I think right now all the dates start in January and go to some end of a quarter in the year. We'll be updating that so that it aligns with the harvest dates instead, which should be more useful for you. It will not impact your ability to type in a custom date range. So you'll still have that capability to put in whatever dates you want. This will just improve the predefined date selections in the drop-down menu.
That's good news.
Yes, very good. And then finally, we do have a fix coming for the formatting of the export on the risk adjusted dashboard. As of now, when you pull that PDF, there are some sections that will be cut off. Either the columns are being pushed onto a second page, or at the bottom of the report, you might be seeing a cutoff. So improvements will be coming to make that better to read and more streamlined for you.
And that's it.
That's it.
All right. And if anybody has a question about an open ticket, please be sure to include your ticket number. And now I'm handing it over to Melinda.
Okay. Hi, everybody. I thought today we'd talk about postoperative stroke. I seem to be getting a lot of questions about postoperative stroke, so I thought it would be good to review it. So this, as you know, this is sequence 6810, and I want to go over the intent of what we're capturing here. So the intent is to capture whether the patient had a postoperative stroke that was confirmed on imaging, or the symptoms did not resolve within 24 hours. So it's not an and, it's an or. So you can either have a positive stroke on imaging post-op, or you can have symptoms such as expressive or receptive aphasia that continue past 24 hours. We had an update in August. We've had some scenarios lately where the neurologist documents the patient had a stroke and the surgeon says, no, that's not a stroke. So we've clarified the training manual to identify that the neurologist is the final arbitrator when there are differences in opinion as to if a stroke occurred post-op. So hopefully that will help with those situations. Next slide. Okay, so there are two forms of stroke. Most commonly, what you're going to see is an ischemic stroke where the blood vessel has been blocked. Usually it's like an embolic stroke. Or less commonly, you might see a hemorrhagic stroke, which is bleeding into or around the brain. Sometimes they call that an intracerebral hemorrhage or a cerebral bleed. What we're not capturing in this sequence, we're not capturing neurological deficits such as confusion or delirium or encephalopathy. We're just looking for stroke in sequence 6810. Next slide. Okay, so just to briefly review the symptoms of the stroke, you know, it's a sudden numbness or weakness, especially on one side of the body. You could have sudden confusion, trouble speaking or understanding speech. You have aphasia, sudden trouble seeing one or both of your eyes, or trouble walking, loss of balance, coordination, paresis, sudden headache with no known cause. So those are just kind of the symptoms. We're not looking for, like I said, delirium. We're not looking for confusion. We're not looking for encephalopathy, which is quite a bit different from an actual stroke. Sometimes patients can have encephalopathy and a stroke. They can have both of the things going on at the same time. Sometimes you'll see documentation of that. The other thing we're not looking for is like an anoxic coma. If the patient arrests and the neurologist documents that the patient has an anoxic coma, and they're basically brain dead. That's not a stroke. That's going to be captured in the encephalopathy field, and that's in the training manual. So we're going to have some scenarios here to see, and some polling questions. Some questions that I get into the mailbox. Now, quite honestly, the questions that I get in the mailbox are usually very long, and I have to go through neuro notes, and I have to go through scans, and so it's hard to present those types of things in this forum. But if you are going to send me a question about a stroke, I'm automatically going to say I need to see the neuro consult, I need to see the scans without identifiers. So sometimes if you just want to go ahead and send that right up front, that helps out. Saves me another email and saves you another email. Okay, so let's go to the next video. All right, so, let me see some of these questions first before we get into the polling questions.
Do you want me to read them to you?
Yeah, I can, yeah.
But some of these you might be covering in your questions.
I might be, but I want to answer Jill's right now. Is
Okay.
stroke captured within the hospitalization only? Well, in sequence 6810, which we're talking about, it's only captured in the hospitalization because that's a post-op event, which is the hospitalization, acute care hospitalization. But we do have a readmit selection for stroke too, if the patient's readmitted with stroke, but that's in a different sequence. That's like 7145. But what we're talking about is a post-op event, which is an event that occurs post-operatively in the acute care hospitalization.
Thanks, Melinda.
Okay. All right. I think the rest of them we're going to save until later. Okay, so let's look at some of these questions and then we'll go over those other questions. I did want to address Jill's quickly though. All right, so question number 1. Patient has a new focal deficit of right hand weakness, documented 0741. The MRI shows acute infarcts, embolic phenomenon is suspected. The patient left AMA the same day, no neurology consult. Would this be captured as a stroke? So A is yes, B is no, and 3 you're unsure.
And the poll's open.
I see that.
And you can see it, right?
I see it.
Melinda? Okay.
Okay.
Yes.
Looks
Oh, let it go.
like everybody's doing a great job here.
Are we good, Melinda?
Mhm.
Okay. All right. We're going to end the poll.
Okay. So 83% of the people got the answer yes, correct. And that is the answer. The next slide. So let's break this down just a little bit. So he had a deficit. They did an MRI. It showed an acute infarct, but the patient left AMA. But the key here is that it showed an acute infarct. So this stroke was confirmed on imaging. So this is a yes, despite the patient leaving AMA that same day or not having a neurology consult. This is a stroke.
Hold on, wait. Okay.
All right. We have another question. On post-op day 1, the patient complains of sudden onset of numbness and heaviness in the right side of his tongue and mouth and difficulty speaking. The patient went for CT, which did not show any acute areas of hemorrhage or areas of infarct. The neurologist states that the patient was not a candidate for TPA or IA. The symptoms resolved within 2 hours. Is this coded as a stroke? Yes, no, or unsure?
Oh, Melinda, you've done a good job at this one.
Yay! Looks like everybody's.
I think we're good.
I think we're good too. So
Oh,
looks like we're at about 97, 98% of the people.
okay. We're going to close the poll down.
Got the correct answer, which is no. So we'll look at that next slide and dissect it a little bit. So first of all, when you look at this scenario, the patient did have symptoms, okay, but those symptoms resolved within 2 hours. He did go for a CT, and the CT, there was no infarct or no hemorrhage. So this is not a stroke. This is a TIA, which we don't capture in version 4.2. So there's really no place to capture this event. Question number 3. A patient had a coronary artery bypass and a carotid endarterectomy done by the cardiac surgeon and the vascular surgeon. So they were operating in at the same setting. The patient had a stroke post-op that was confirmed on imaging. However, it was documented in the progress notes that the stroke was from the CEA. Do I code this as a post-op stroke? Yes,
Ooh, you're
no, or unsure?
so tricky, Melinda. So tricky.
Hey, I don't make these questions up. These are the questions they send me.
Tricky.
They are tricky.
Hmm.
I get some good questions.
It's still, we're going to let her run just for a little bit. I would question this one too, but I know the, of course we know the answer, but I would definitely, it's a good one. All right, we're going to end it here. I think we're good. All right.
Okay, so 89 of the participants participating in this poll got the answer correctly, and the answer is yes. Okay, so the bottom line here is this patient had a stroke. The field is not asking you what caused the stroke. It's asking you if the patient had a stroke. And this patient had a stroke. It was confirmed on imaging. So despite the cause, we would still code this as a postoperative stroke because the event occurred post-CABG and the other procedure that was performed in the CABG. All right.
Okay.
I think we have just a couple more. So question number 4. Post-op day 2, patient developed aphasia and confusion post-narcotic administration. So they called a code stroke. The MRI showed a tiny acute infarct in the right parietal lobe. Patient's symptoms completely resolved in less than 24 hours. The neurologist noted that the aphasia was likely associated with a narcotic administration. Also, a tiny asymptomatic right parietal infarct. Does this still get coded as a post-op stroke?
Oh, this is tricky.
No, or
This is another
unsure?
tricky one. These are good, Melinda.
Yeah.
Yeah, I knew it's gonna be split.
This one's gonna be a little more split.
I'm arguing with myself inside my head with this one right now. You think people are opening the training manual to see if it's in there? Okay. Are we good to stop it?
Yeah, I guess so. We've got kind of a split on this one. 65.
Yeah, it's tricky. Okay, we're gonna end it.
33. Yeah, okay. So let's see what the answer is. So the answer is yes. So we'll break it down a little bit. The main thing here is this patient had an MRI and there was an acute infarct, meaning that that's a new stroke. Despite the symptoms resolving, this stroke was confirmed on imaging. So, and despite what the neurologist says, oh, the aphasia is probably associated with narcotics. Well, it could have been, or it could have been associated with a stroke. He also said that the patient had a stroke in the same sentence. So this is a stroke, mainly because it was confirmed on the MRI, an acute infarct.
Okay, tell me if I'm gonna get ahead of myself on here. With this, what I'm gonna ask, but what if it was a chronic infarct or an old infarct? Am I getting too ahead of myself on this? Or is this covered in another
if it's
question?
an old infarct, then okay. So when people send me questions like that, the first thing I say is, like sometimes they don't hardly ever send old infarct because they know that that's occurred. Usually old infarcts are like 30+ days. It's been a long time since you've had that. They send me a lot of acute to subacute infarct questions. I get those questions a lot. And the first thing I ask them is when the patient had surgery and when the patient had the head scan done,
Yeah.
because subacute can be as little as, within 5 days, right? After the event, up to, I think it's a couple of weeks. So you have to kind of just, so when you see acute to subacute, you got to ask yourself, well, when did the patient have surgery? How long has it been since he had surgery and now he's having this scan? Did he have a scan pre-op? was there any evidence that this patient had symptoms or had a stroke pre-op? But, you know, so you have to kind of dissect it down a little more. This one's pretty easy because it says acute infarct. As ones that are harder to dissect down are the ones where the patient had surgery 5 days ago, and then it says subacute infarct, you know, 5 days later. So you're like, okay, but the patient has symptoms, generally speaking. They do have symptoms. So they've got these symptoms that they didn't have pre-op. So
Yeah,
clearly something happened to them.
that's good. Thank you. Thanks.
Welcome. Next question. Okay. We recently had a patient that had speech difficulty and episodes of aphasia for 48 to 72 hours post-op. The CT scan was negative. The neurologist states it was a stroke, but the CT surgeon feels it was not a stroke. Do I code it as a stroke? Yes, no, or unsure?
Ooh. People don't want to have those difficult conversations, I guess.
Either that or they missed it when I gave the answer earlier. They caught the call late.
Okay. I think we're good. We're going to stop it here.
So 88% of the participants got the correct answer, which is yes. Okay, so let's break this down too a little bit. So this patient's having aphasia, difficulty speech, and it's going on 48 to 72 hours post-op. Okay, so it went on for longer than 24 hours, right? That's a key. The second key here is that we, in August of this year, we made a statement in the training manual that if we have differences of opinion as to whether a stroke occurred or not, the neurologist is the final arbitrator where there's differences in opinion. So in this particular situation, not only did the patient have symptoms that didn't resolve within 24 hours, but the neurologist is saying, hey, this person had a stroke, despite the negative CT scan. But you don't have to have a positive CT scan. You can have symptoms that don't resolve within 24 hours or positive imaging, or you can have sometimes you have both, but sometimes you don't always have both, but you can have one or the other, as on the when we went over the intent and the definition. So it's stroke-like symptoms that don't resolve, that last longer than 24 hours, or positive imaging that a stroke occurred. Is that my last question? I think it is.
Yep.
Yeah,
I had questions.
I had trouble finding questions because even though I get a lot of questions, I had trouble finding short questions and questions that we could easily break down. So I apologize. There's only 5.
No, those were good, and they provoked a lot of questions here. So if they have one-sided weakness that is resolved by 24 hours, that is resolving by 24 hours and is resolved completely with a negative CT scan, would that be no on stroke?
Well,
how do you code that?
If the weakness resolved within 24 hours and the scan is negative, then that's not a stroke.
And what if it's resolving but not completely resolved at 24 hours?
That is resolving and is resolved completely. I guess I don't. If it lasts longer than 24 hours, then it's a stroke by definition in the training manual.
Okay. What about aneurysmal SAH strokes?
Yeah, this is a little, okay, this gets into kind of a gray area. So we'll talk about, I knew this was going to come up. Let's talk about subarachnoid hemorrhages. So technically, a subarachnoid hemorrhage in it of itself is not a stroke, but it can cause a stroke. So when a person has a subarachnoid hemorrhage, the key is to look and see if there's documentation that a stroke also occurred with it. because not all subarachnoid hemorrhages are going to cause a stroke, but some can. So that's kind of the key there. We do have what sequence is that where we capture bleeding in the brain? Trying to
The
think.
bleeding events, the anticoagulation events.
Yeah, I'm trying to think what number that sequence is.
Let's see if we can find it. Hold on.
I should know this one, but I don't get a lot of questions on this one, so I
It's
don't
okay,
have it
let's open it.
memorized. Oh, here it is, 6930. I found it. So if we had, Erica, if you had a subarachnoid hemorrhage that did not cause a stroke, you would capture that in sequence 6930 if it was related to an anticoagulant bleeding event. So, so let's just say the patient got way too much heparin or way too much Coumadin or whatever, and they bled in their head and they had a subarachnoid hemorrhage. Well, that would be coded in 6929 because not all subarachnoid hemorrhages are strokes. Some might progress to a stroke, some might not.
What about subdural bleeds?
That's kind of the same concept. Usually a subdural does not cause a stroke. And it can also be captured in 6929 if it's related to anticoagulation. I had a question the other day, somebody sent in, somebody fell, they actually fell post-op and had a bleed. And there really wasn't any place to code that because it wasn't related to anticoagulant. It was a mechanical fall. The patient didn't, so we don't capture all events. Okay, so what does that Barb say? You stated pre-op stroke. What does that mean?
I don't know. This one was early on.
I don't know what that means, Barb.
Is this coded as pre-op stroke? Oh, for question 3. Yeah, that's what I was kind of for question 3. And I was kind of alluding to that. For not question 3. No, I was thinking of question 4. Maybe, I don't know.
3 people have their hands raised.
Okay,
Maybe
hold
they
on.
want to help us.
Yeah, let's get some help. Okay. Okay,
Yeah,
Erica.
The way your poll questions were written, it says, would this be considered a pre-op stroke instead of post-op stroke? It was a typo in your poll question that she's referring to.
Thank you.
All of them said pre-op instead of post-op.
Really? In the polling questions?
Yeah, within the questions when the poll came up.
Oh,
it says pre-op.
See, Melinda, that's me. I'm sorry, everybody.
And so that's why everyone was confused.
But everybody did a great job.
Carol.
Listen to I'm sorry. Listen, so sorry, you guys, everybody. Did I really?
But it was the same on all of them, so it was consistent.
Sorry.
Yeah, because it was I only put in one poll question, and I just redid it. I'm so sorry, but everybody did great, and I'm sorry if I caused confusion.
I guess everybody kind of knew while we were talking about post-op stroke, so I'm sorry, guys.
Oh, I love it.
I didn't even read the poll questions. I was just reading my slides. Oh, for God's sake.
Sorry.
Okay. It's all right. Okay, so let's go back to
all right, Danette. Melinda's going to fire me. Okay, so to confirm, we do not require a provider diagnosis of stroke if there is imaging that shows acute infarct.
Well, okay, imaging is who read the image? I mean, that's the question I asked myself. So a neurologist or somebody read that, some provider read that event that it occurred. So yeah, if you got positive imaging that was read by a provider, and that's a stroke.
Oops, wrong side. Okay, next question is for question 4. Is there a neurological deficit though?
Doesn't have to have one. They had a stroke on the MRI. They had some aphasia resolved. in less than 24 hours, but they had a stroke on the MRI. So this is a stroke. I have a friend that had the same. She had a little brainstem stroke. Symptoms didn't last very long, but she still had a stroke, and it was confirmed on imaging. So, and she still, the care provided was still provided for a stroke. She still gets followed for it. Okay. Let's see.
And next time somebody stop me when the polling questions are wrong, like quicker, quicker. All right. I think you may have answered this one about again regarding subacute infarcts without neuro consult to clarify and resolving within 24 hours.
Yeah, subacute infarcts. I usually ask for a lot more documentation. I want to see progress notes. I want to know exactly when the surgery happened, exactly when, the symptoms began, and when did they actually do the scan. Because, like I said, subacute is kind of terminology that it's can be broad. It can be like as little as 5 days up to 2 weeks. So it's kind of broad, and it's that makes it more difficult for us when it says subacute. Now, if it says acute to subacute, okay, that makes to me that's pretty definite that there's an acute element of this event.
I think this was a great topic. Here's another really good question, and I'm sure that it's not this site only who have this, because I know when I was abstracting, I had a lot of questions about this post-operative event section. So just want to confirm the answer to the earlier question, because we had a patient who had a stroke 1.5 weeks after discharge, that this is not considered a post-operative stroke. Our abstractors coded it as yes, and I, for some reason, thought it was considered a stroke if within 30 days of discharge, kind of like the way we capture mortality within 30 days.
No.
That's correct. It's not. So
Yeah.
what we capture within 30 days is the mortality and then the surgical site complications up to 30 days or during an initial hospitalization for surgical site infections. These other complications, these are in-hospital post-operative events. So if they occur during the initial acute care stay, that's when these are captured. And that includes the post-operative stroke.
Right. In this situation, if this patient had been readmitted within the 30 days, then it would go under the readmit section with the stroke.
Okay. I have 2 hands raised. Are you there? You could go ahead and unmute. MMCK. Oh, okay. And then Melissa Williams.
Yes, I would just want to go back to the question I asked about question number 4. The definition in the training manual says indicate whether the patient has a postoperative stroke, parentheses, i.e. any confirmed neurological deficit. So even before it says whether it was confirmed on imaging or did not resolve, the definition does state there needs to be a neurological deficit.
Go further down into the intent. That's where we can't change definitions once the definitions come out. We can only clarify information in the intent as to what we actually want to capture in the field.
So the phrase about confirmed neurological deficit actually does not apply?
What's the sequence number, Melinda?
6810.
6810, yeah.
Okay, let's pull it up.
Make that a little bit bigger.
Yeah.
Okay, so a neurological deficit can be confirmed on imaging or by symptoms. Okay, so
But the deficit can't be confirmed on imaging,
on
right?
question number 4, the patient had aphasia, if I'm not mistaken. They did have a deficit. Correct.
But the neurologist said that that was thought to be related to the medication.
Well, that's what he thought, but he was presuming that. But there was a deficit that the patient did not have pre-op, despite the deficit only lasting, I can't remember the exact question, But it didn't last longer than 24 hours. So as a result of that deficit, they did an MRI on the patient and discovered that the patient had a stroke. So there was a deficit, it just didn't last 24 hours. So in the definition, the intent section, the stroke can either be confirmed on imaging or symptoms or deficits did not resolve within 24 hours. Does that make it clear?
I guess the confusing thing is still the update that says the neurologist is the final arbitrator, and then the comment in the question about the neurologist's kind of determination in this case.
But if you look at his comment, I can't see it because the training means, if you look at, this is exactly what he said. The neurologist noted that the aphasia was likely associated with narcotic administration, and then his semicolon, tiny asymptomatic, right? Frail?
Asymptomatic. Yep, he said it was asymptomatic.
But he still said the patient had a stroke right there. Do you see what I'm saying? He
They
had
still
a-
But
has
an
a-
infarct isn't the same as a stroke, I guess, is what I'm trying to like.
No, it is an infarct. Is when they call that an infarct, that's a stroke.
Asymptomatic infarcts or strokes.
He had an infarct in his brain on the imaging.
That was asymptomatic.
He had a.
It doesn't matter if it's symptomatic or not. He still had the infarct.
Yeah, he had the infarct.
Okay.
That's why these were FAQs, because they're tricky.
They are tricky.
Yeah.
Thank you.
You're
Mhm.
welcome. Okay, so
Okay.
anybody else had their hands raised?
Oh, Erica. Okay, Erica.
Three people have their hands raised.
No, I got two.
Oh,
There-
Did I
Okay.
unmute myself?
Yes, ma'am.
Okay, sorry, I was trying to figure out how to unmute myself. So just, I think to help with the last question, so on question 4, if the neurologist had not said that that tiny infarct was there, I think that's what's holding people up, is because in one place we say the neurologist is the final word, but then at the same time we're saying no, the imaging is the final word. And you said that, you know, there is a provider, obviously usually a neuro rad, that is reading the MRI. So you would then have a neuro rad saying it is a stroke, but then you would have a neurologist saying it's not a stroke. And if,
Well, I think what happens here is the neurologist never says it's not a stroke.
right, I get that for this one, absolutely.
Yeah.
I
But
think
what-
that's where some of the confusion is.
Yeah, you don't have the neurologist saying the patient did not have a stroke. The patient symptoms were a result of narcotic administration, no stroke present. You don't have that documentation.
Right.
You have the neurologist saying that the patient had aphasia, likely related to narcotic administration, and that there was a right parietal infarct. Even though that infarct is asymptomatic, it's still present. And that means that the patient had blood flow impairment, right?
Mhm.
So there's still something going on there. Now, if you have a neurologist reading the CAT scan or MRI, and you have a neurologist doing another documentation, then I think you need to, that the neuro rad says that the patient has an infarct, and clearly that's an infarct. You have an infarct. I think when
can
we
see
talk
it.
about, clearly it's an infarct. When we talk about discrepancies between the neurologist being the final arbitrator against, what a surgeon may say, what we're talking about is the neurologist saying that patient had an infarct or the patient did not have an infarct, and the surgeon saying something different. It's
yeah, which you see a lot.
Yep.
yeah, we always see the
That
surgeon.
makes
Yeah.
that makes sense to me. I had a follow-up question on the subarachnoids as well, though. So an aneurysmal subarachnoid that ruptures would not be considered a post-op stroke, but that second, the bleeding spec, I can't remember.
Oh, 6930, the
Yeah, that one.
anticoagulation.
That one. It only says intracerebral or subdural. It does not give you an option for subarachnoid. Are we to?
Intracerebral includes subarachnoid.
Okay.
If it's related to an anticoagulation issue. If this is an aneurysm that ruptured, without knowing the situation, 'cause I don't know it, I would suspect that it wasn't related to anticoagulation. And I also suspect it might have caused stroke-like symptoms if it, depending on how big it was. So, you know, it all depend on exactly what happened with the particular patient and the whys. Why did that aneurysm burst? Things of that nature.
Thank you.
You're welcome.
I think Sherry Lynn puts a good comment in here, and it's a really great comparison. She says it's like a patient with a silent MI, and that's exactly right. Is these asymptomatic infarcts are like silent MIs. You don't see the symptoms, but it's still there,
Yeah, and the damage to the heart is still there.
and the damage to the brain is still there.
Exactly.
Okay, Melinda. But even if the stroke is confirmed, if symptoms resolve, aren't we supposed to code as no?
No, that's not correct.
Correct.
Because
In less than no, if the infarct is there, it doesn't matter if the symptoms are there or not, or if they are there, they resolve within 24 hours. If there's an infarct, it's an infarct, and it's considered a stroke.
correct.
Okay.
I think we went through that one. I think we've discussed that already.
Yeah.
Uh,
I think what happens is we like to try to guess what we like to make inferences of what we're reading in physicians' notes when we're trying to do abstraction. And when we don't see something that is black and white, we try to make up what we think they're trying to say. So this neurologist says that the aphasia is likely associated with narcotic administration. And so we assume that the aphasia is the only thing that we would ever use to code. In this scenario, the aphasia is the only thing that we would ever use to code a stroke, but that's not true. The patient can have multiple things going on, as we know. So they could have aphasia, which probably is related to the narcotic administration, and same thing with the confusion. But we can't make that assumption that the neurologist is saying that the patient didn't have a stroke because the aphasia is likely related to narcotic administration. We can't make that assumption. We have to read the whole sentence and look at the whole picture and see that there is an infarct, and that infarct is what we're going to consider a stroke, even if it's asymptomatic. I think that's what happens a lot. I think we like to, and when I say we, I'm including me in that too, doing chart reviews and things like that. We try to make assumptions about what's provided to us. Kind of got to break it down into the pieces of all the information and then put the picture back together about what's going on. These are tricky ones, and that's why they come in.
well, that's the one thing I've learned about doing this job.
Yeah.
Don't make assumptions. Get as much information as you can, because, you know, I'm just reading an email that somebody sent to me, and I have to try to. Sometimes I don't read it correctly. I've had people send me answer back and said, "Are you sure about that?" And then I read it again. I'm like, "Oh my God, why did I answer it that way?" So
Yeah.
you have to kind of just, it's you do have to try to keep your assumptions and thoughts out of it sometimes, and just kind of try to make it as black and white as you can, because a lot of times it's really gray.
Sarah asked to show, yeah, that's great information. Great guidance, Melinda. Sarah asked to show the first question again. So there it is. And then Mary says, this is a good one. If the neurologist says no stroke and MRI shows no stroke, but the patient had symptoms over 24 hours. How is that coded, Melinda?
Well, my first question is, what kind of symptoms? What are the notes attributing the symptoms to? I mean, did the patient have spinal cord paralysis? Was it an aortic procedure and gone bad, and they've got spinal cord issues, or is it the patient having encephalopathy? And so that's the first thing you need to know. I would need to know, what are the symptoms, and what is the providers, what are they saying is attributing to these symptoms? Because
Yeah. Because I would think that if neuro was consulted, I would think that they were consulted for the symptoms, so they would address those in the consult.
yeah, because the symptoms of stroke can sometimes mimic other things too that can be going on, like encephalopathy or spinal cord ischemia, which we have a separate sequence for that. Can't remember the exact one. So I always look to the documentation to see what people think is causing the symptoms. I had a couple of weeks ago, I had a really good scenario, and finally, after reading everything, I just said, well, I don't think there's enough evidence here to say there's a stroke, even though the patient had symptoms. They were attributing the symptoms to other things, and so you just got to kind of look at the whole picture.
Mm-hmm. Okay. Anne-Marie, we don't have that in place yet to identify if a patient was previously entered into REDCap for the devices, but if you could email me, I can help you with pulling a list from your site. Are strokes captured as yes after discharge if the patient has been discharged in strokes within 30 days from surgery? No, it's only within the acute hospital stay.
Yeah, the only time you do that is if it was a readmit within the 30 days. Then it would be captured in the readmit section.
Yeah. If in the LAAO registry, right, if the signs and symptoms are less than 24 hours, and it's always a TIA, even if there's ischemia on the CT. We do not do that in adult cardiac in any of our databases for STS. I'm not sure how the TVT registry is, because those the ischemia on the CT has lasting impact on those patients and can be attributed to the surgery. It is complicated. So yeah, I'm going to respond in writing to you, Nancy. It is complicated because the left side of the brain is usually related to speech deficits. That is why the neurologist dismissed the aphasia as being related. And that's a really great point. And that is putting on, the clinical hat that that we use in doing chart reviews and pulling data for the databases, thinking about why the physician said that. It's a really great point. And I think it also helps if when we see that type of documentation from the neurologist, is to go ask them why they think that, or why they don't believe that the tiny asymptomatic, why are they calling this infarct asymptomatic when the patient does have some type of deficit, what could be a neurological deficit. Why are they saying that this is asymptomatic? So you have conflicting information from the neurologist, and there's probably a really great reason why. And that's exactly what Nancy's saying, is that the left side is related to the speech. The infarct was on the right side. So that's a great time to speak to the neurologist and learn from them and ask questions, because they'll explain it to you. To cover that. Okay, I can understand the sentiments of the cardiothoracic provider if post-op stroke is attributed to them, if it's clearly from CEA. I think the point to that one, Glace, is that how do we know it's clearly attributed to the CEA? And not only that, but the surgeon agreed to do the surgery at the same time as the CEA was performed. So it's one procedure, two procedures at the same time on that patient. It likely is captured in the vascular surgery database because there is no way to define when that stroke occurred. or what caused it. And it could have been a combination of both procedures being done together.
Yeah, and on another note, it's not an analyzed cabbage anymore. It's not an isolated cabbage anymore.
Yeah, so it's not going to hurt them.
When they do it
Sometimes you identify the symptoms of a stroke a few days later when you realize the two go together. My sister had trouble typing words and texting from her stroke.
Mm.
I'm sorry to hear about that, Beth.
Yeah.
Yeah, good point. Yeah, or a UTI in a patient that has a history of prior stroke. They mimic strokes, especially elderly patients. They're going to have those neurological symptoms from UTIs that are very difficult to figure out if it's from the stroke or from the UTI. In question 1, this deficit could be from OR positioning without a 24 assessment. You don't really know.
I don't remember question 1.
Oh, right-handed. Yeah, that's a good point too.
Yeah, except that the MRI showed an acute infarct. So
Yeah.
that's the key there.
So what if symptoms are less than 24 hours, MRI is acute infarct, and neuro states no stroke? I don't know
think
that
I've
that
ever seen.
happens.
I don't think that would ever happen.
Yeah, I don't know that I've seen that one.
I've never seen that happen. I've never seen the neurologist say the MRI is wrong. Yeah,
Okay.
but please, if you guys find an example like that,
Yeah.
send it to Carol.
Thanks, Linda. That's funny. Okay, yeah, so I could say, oh, is this a pre-op risk factor? Okay, sorry, just kidding. Wouldn't you only capture the stroke on readmission if that was the primary reason for readmission? So if the patient's readmitted for a stroke, it's not going to go under the post-operative events.
Right.
But it would go under the readmission and then the, where'd it go?
I think there's a stroke one there. Yeah, there's a stroke one.
Oh,
yeah,
there it is. Stroke.
Right.
I think it's important to remember that an incidental finding of an acute infarct is still a post-op stroke, even if it didn't cause the deficit. Yeah, that's a great way to summarize. That's a great way to summarize the discussion today. Thanks, Erica. Okay.
Do we have any other hands raised?
Good examples, Melinda. I agree. They were tricky. All right, let's see. We do have a couple. Erica, I don't know if your hand is raised. Feel free to go ahead if you had something. Nope. Okay. And then Trisha, go ahead. If you're there, you just have to unmute yourself. Hello? I see you're unmuted, but I can't hear you. Okay, and then Jessica, go ahead. You just have to unmute yourself. Okay, nobody wants to talk. Trisha, we could try again. And then Melinda, Trisha, just let us know if you're there. I can't hear you though. Melinda, one more question, and then we'll have to end the call. If the stroke was not the primary reason for readmission, they code the primary reason. Okay.
Yeah.
If it's not the primary reason, then just you would code whatever the primary reason is for readmission. Different topic. Okay, last one, Nancy, and then we have to end the call for today. Our surgeons have cardiac rehab 1, phase 1 during surgery. That's probably right, a post-op. There's a note that they will decide when rehab would start after the first post-op exam to evaluate the stability of the sternum. I would still code that as the patient having rehab ordered because they're planning on phase 2. Melinda, what do we say?
It depends, Nancy. Was phase 2 discussed with the patient? Was there an appointment made? Was there, I mean, if you go to sequence 7.
Well, I don't think you can start phase 2 until you have a stress test though, right? So there just has to be some type of referral or plan.
Right, but you have to have this specific documentation here. So you got to have some advice or discussion with the family and the patient about the importance. You just can't write an order. There's got to be some active discussion. That's one thing, or you've got to be, the patient's got to be educated on cardiac rehab exercises to do at home, or they've got to have an appointment made. So it kind of depends, Nancy. You know,
She says
what
they
was the
discuss
motion?
it with the patient.
Okay, good.
Yeah,
then.
yeah. Okay, I guess we're good, everybody. Thanks for joining,
Yes.
Melinda. Great conversations, tricky questions.
All right.
Thanks everybody for joining. I hope you have a good rest of the day, and we'll see you all. I don't know when. Hold on, I'll tell you when. Oops.
Oh, we have a special speaker next call.
Oh
don't
yeah, we have a special speaker for the 21st. Please join if you're available. It will be a great talk, and I'm not going to share any more information because I want to leave it mysterious. I really do hope you all can join and support our peer data manager in her presentation to us on a quality initiative that they instituted at their hospital regarding charting. All right, thanks everybody for joining. Have a great rest of the day, and take care. Oh, the next webinar is the 21st, September 21st. All right, thanks everybody. Thanks Melinda. Thanks all. Bye.
All right, bye.